Okay, so good morning everyone. Today we will continue with our presentation from yesterday on the signs of the brain. Today will be the part 2. We'll see how many parts we will need to finish that because there are a lot of signs in the brain. Like really a lot. Anyway, so what do you think is going on here? What's the sign? What's the diagnosis? Do you have any idea about the diagnosis? Exactly. This is central pontine myelinosis, or this is the old name. The new name, they call it osmotic demyelination syndrome. They changed the name. Well, it's the same thing. I don't know why they changed it, but anyway. So, what's the sign? We'll discuss the disease later, but what's the name of the sign that you see here? It has two signs. Okay, just a second. You have this one. This is a sign, and this is another sign. This, they call it bat wing or butterfly appearance. Okay, bat wing or butterfly. Of course, you can see it looks like a bat wing or butterfly, some sort of. Anyway, and this is, they call it the trident appearance. Okay, you can see this is the trident. Poseidon, the god of the sea, has this trident. Okay, and this is the bat wing, and it's not very nice bat, but anyway, this is what I could find. So there is central pontine hyperintensity spanning the tegmentum ventrally and corticospinal tracts laterally, which is due to osmotic demyelination syndrome. Previously, it was known as central pontine myelinosis and extrapontine myelinosis, CPM, EPM, a lot of I don't know what, refers to acute demyelination caused by what? Rapid change in the serum osmolarity. This happens when there is an alcoholic patient, he's hyponatremic due to frequent vomiting. Okay, rapid correlation of the blood osmolarity results in exactly becomes better, then deteriorates rapidly. This is due to the massive fluid influx from the brain into the serum, resulting in symmetrical T2 hyperintense signal and reduced diffusion, means increased signal on diffusion. If you make a diffusion for this, it will be restricted in diffusion. Okay, in the central pons, basal ganglia, and or cerebral white matter. Mild injury can produce signal abnormalities in the median raphe and basis pontis, and with a bilobed or bat wing triangular trident morphology. You can see either trident shape or bat wing shape. This is with the mild cases. When it gets more severe, it will get more outside the brain stem, let's say. Okay. When it's more severe, it will start affecting the entire pons with the sparing of the tegmentum, corticobulbar and corticospinal tracts. These three things will be spared. This is called snake eye appearance. You will see, it's not seen here, but maybe you'll see it later. Okay. In the subacute period, the signal will change, improve, or resolve completely. Later, it will improve or resolve for the treatment. Okay. What's the differential diagnosis of this appearance? Other possible differential diagnosis? Of course, infarction is number one. Neoplasms, demyelination, infection, and metabolic disorders, radiation. But this is more in favor of central pontine myelinosis or osmotic demyelination syndrome. Of course, history and clinical presentation will be of paramount importance in these cases. Good. So, what do you see here? What do we have here? This is an adult brain, T2, axial, brain at the level of the cerebral hemisphere and at the level of the cerebellum. And there are two arrows on the cerebellum. What do you think is going on? He's an adult. For disease.
Hyperintensity signal and what?
Exactly. So there is what? Increased T2 signal intensity seen affecting what? affecting the brain, the cerebrum, sorry. General, diffuse. This, while the cerebellum is dark, okay? It's called dark cerebellum or black cerebellum sign, okay? Which is exactly the opposite of what you see in the CT scan, the preserved cerebellum or hyperdense cerebellum sign. Because it appears, the cerebrum appears dark on the CT scan due to what? Due to edema. And the MRI, the edema will be what? So it will be exactly the opposite. It will be increased signal intensity on the MRI, okay? So you can see diffuse edema with abnormal hyperintense cortex and gyral swelling, طبعا on the brain MRI, on the T2, okay? You can see it obviously here. I told you this is an adult, not a child. So you have to treat it like we normal see brain. This is not normal, of course, but the more diffuse signal abnormality, the more difficult to be seen. Okay? And this is the normal cerebellum. This is the normal pattern that we usually see. Okay? So this looks dark related to this. Both of them are T2. Okay? Due to diffuse cerebral edema. Okay, this is occurring in various settings, including trauma, hypoxia, ischemia, infection, and there is relative. Sorry, what's going on? There's something wrong. And there is relative sparing of the basal ganglia and the brainstem and cerebellum. Preserved cerebellum will appear bright than edematous cerebrum on the CT. This is the white cerebellum sign. Exactly the opposite on the MRI. It will be the dark cerebellum sign, okay? Which is, like as we said, the reverse of the normal appearance. Okay? So keep that in mind. If it is an MRI, it will be exactly the opposite. Okay? Now, what do you think is going? This is a T1. No, just once. We are just looking for the sign, not for the disease or the. These are what's called periventricular gray matter, hypo-intense signals. What's the sign? Sorry? No, this is not a central dot sign. This is called black hole. These are black holes, ثقوب سوداء. Okay? Exactly. This is, I think, the picture of the black hole is different from that. The recent one published by the scientist, I don't know who. Anyway, so this is an contrast T1 with multiple T1 hypo-intense non-enhancing periventricular foci. And this has a differential diagnosis of either demyelination or focal encephalomalacia. يعني either multiple lacunar infarcts, focal encephalomalacias, or demyelination. Of course, this is more in favor of. Sorry. Exactly. This is much more in favor of demyelination, but as another differential diagnosis, if you like to make another differential. Okay. So demyelination, what we mean by that is MS, multiple sclerosis. What the hell is wrong with this computer? Okay. It's a burnt out lesion. It's an inactive lesion. Okay. The acute is present with edema and enhancement, may be diffusion restriction. In the chronic stage, there will be gliotic black holes. These are hypodense on CT, hypointense on T1, and non-enhancing, okay? Which there is moderate correlation between the development of the black hole and the degree of the clinical disability in MS. Some correlation. How much black holes and how much clinical is he disabled or not? Okay? So the more the worse. Yeah, but it's not strong correlation, it's mild to moderate, okay? Focal encephalomalacia can be caused by ischemia, infection, or trauma. Can demonstrate similar imaging characteristics, though the spatial distribution disorders differs from that of MS. You know, the MS has spatial and temporal distribution. In the focal encephalomalacia, it's different age group, different kind of presentation, different, everything is different. Maybe the findings can be a little bit lookalike, okay?
Can I put sub-pendymal this one?
The appearance on the,
Nodular.
I know. First of all, it is not subependymal, it's periventricular. First, second, it does not follow the feature of the gray matter on all sequences.
We should have all of this.
Okay, you don't see one image when you are interpreting, and any patient you have a lot of images and sequences, so you have to, plus the clinical manifestation, of course, you have to put it all together. Okay, here we are here just for the sign, the name of the sign. Okay, what do we have here? It is, in fact, relatively specific sign. Small head of the caudate nucleus, exactly, which indicates the sign what? The disease.
I saw it in the spots.
Huh.
Small caudate.
Come on, guys, girls.
Not much.
No, it's not Yabani.
Not much.
No. Huntington disease, exactly. Huntington is not a Japanese name, it's a Western name. So, what's the sign? It's a boxcar ventricle.
Yes.
Boxcar ventricle. The boxcar is the container that they load the things in the big things, the big cars, they put stuff in it and ship it to different parts of the country. Trailer. I have no idea what's the relation, but this is the name, okay? It's a little bit of box. Okay, there is atrophy of the caudate nucleus resulting in enlargement and squaring of the frontal horns. Mostly it is Huntington, other possible neurodegenerative disease. So, what's the mode of inheritance of Huntington disease? No. No. It is autosomal dominant. Okay? The only one that's left. Hey, I don't know what's wrong with this mouse. Damn it. Anyway. So it's an autosomal dominant disorder. Usually onset where? Middle age. Have anyone seen the TV series House?
Yeah.
House is Doctor, the crazy one. His resident has Huntington disease, and she starts onset in middle age. The beautiful girl, the one. No, the tall, dark hair. Anyway, say it again. Okay, she has Huntington's disease that starts onset in middle age. Okay, usually presents with chorea, psychiatric problem, and the progressive cognitive decline. And the imaging shows selective atrophy of the basal ganglia, especially the caudate nucleus. Okay, this produces characteristic squaring of the frontal horns, which are called boxcar ventricles. Findings may be difficult to distinguish from age-related changes and other dementing disorders. Correlation with the clinical symptoms is crucial. Again, clinical is important. That's why we call it clinical radiology, not photography. Okay? So, what do you see here? Hyperintense basal ganglia. What's the name? Almost got it. It's the bright basal ganglia sign. Okay? Can anybody knows the differential? It has a differential. What? Okay. First of all, it's toxic poisoning. CO poisoning, exactly. First differential. Others include metabolic derangements and neurodegenerative disorders, vascular conditions, okay, anti-inflammation, inflammatory diseases, infections, and malignancy. You have increased T2 signal intensity of the basal ganglia. The basal ganglia should be less hyperintense on the T2 images. This is a bright ganglia sign. So on the MRI, the hyperintensity on T2 and or T1 weighted sequences, the bright basal ganglia can be seen with various etiologies, including toxic, metabolic, and neurodegenerative. I hate this. What's going on? Sorry. Can be with toxic, metabolic, neurodegenerative, vascular, inflammatory, infectious, neoplastic conditions. The toxic etiologies includes, like we said, carbon monoxide poisoning, methanol poisoning, okay? And keep in mind cyanide poisoning also can give you the similar appearance. Other metabolic conditions include liver disease, that is the hepatic encephalopathy, hyperglycemia, hypoglycemia, toxic ischemic encephalopathy, hemolytic uremic syndromes can cause this, mitochondrial disorders, osmotic myelinosis, as we said, can affect the basal ganglia also. Exactly. Wernicke's encephalopathy. Neurodegenerative disorders includes Huntington, dysmyelinating disorder, neurodegeneration, with brain iron accumulation, Creutzfeldt-Jacobs disease, the mad cow disease, طبعا. Okay. Farr disease can cause this bright basal ganglia. Vascular abnormalities including venous thrombosis, arterial infarction, inflammatory infectious disorders including viral encephalitis. So it's bright, very non-specific sign, okay? Other features systemic lupus erythematosus, Behçet disease, neoplasms including CNS lymphoma and glioma. However, bilateral symmetrical will be very unlikely, okay? You should look for evidence of reduced diffusion, hemorrhage, contrast, mass effect, clinical history, time course, additional abnormalities of the thalamus, cerebral cortex, corpus callosum, white matter, cerebellum, brainstem can also help to narrow the differential diagnosis. So just picking up the bright basal ganglia sign is very non-specific. There is something wrong, but which one is it? You have to depend on the other sequences and the clinical history and the lab and whatever. Okay? So, exactly. That's exact opposite of what we saw previously. Okay? This is the bright, dense, white cerebellum, reversal sign, whatever you like, call it. It's again in the diffuse cerebral edema. And as we said, just a quick review, causes include trauma, hypoxia, ischemia, and infection, in which there is relative sparing of the basal ganglia, the brainstem, and the cerebellum. There is the exact mechanism, they're not sure why the cerebellum and the basal ganglia. A lot of theories, but it's not. There are few theories, but none of them is completely. Some say due to sympathetic, some say due to venous drainage, some say due to arterial supply. Who cares? Anyway, again in the MRI, it's a black cerebellum sign, which is the reversal of the normal appearance. Okay, you can see the cerebellum is white compared with the cerebrum. For me, I have seen a few cases. All of them were due to ischemia, yani hypoventilation, hypoxia. All of them were in the ICU, and most of them died a few days ago after. Usually cardiac arrest with a CPR, long time, relatively long time, like for example 10 or 20 minutes of CPR. They usually does not regain consciousness. It does not mean a brain death. This sign does not mean a brain death, but it has a very bad prognosis. Okay? So, what do you think is going on here? There is a mass. Okay? What feature of this mass? Sorry? Well, other possibilities? No, not the diagnosis. What's the feature? The sign. This is what we use, the word we use to describe this is bubbly, feathery, soap bubble, Swiss cheese. All of these criteria you can use to describe this kind of a mass. It can be like Swiss cheese, like multiple areas of hyper intense, and you can see the bubbly appearance, feathery. It's not homogeneous, it's heterogeneous, okay? And this, the differential diagnosis here is what? central neurocytoma and
Tumor cell,
central neurocytoma due to other possibility,
Papillary.
bubbly appearance mass,
Bubbly appearance, we have linear, but not appear. Not okay.
bubbly appearing mass can be central neurocytoma or leave the location and the just as a differential. Leave the image. Don't look in general.
General linear.
Yeah, exactly. What? Oligo dendroglioma and central neurocytoma.
Typical location for it.
I told you, leave the image. Don't. The mass that you use this term, the bubbly appearance, the soap bubble appearance, the Swiss cheese appearance, the feathery appearance, without looking at an image, just when you hear that, you keep the two things in mind. Either central neurocytoma or oligodendroglioma. It's one of the two, okay? You can see here a multilocular lesion in the left lateral ventricle attached to the septum pellucidum. It has some blood fluid level in the frontal horn, you can see here. Okay, this is the first image, and the second image, a multilocular lesion in the right cingulate gyrus with infiltrative surrounding hyperintense signal due to طبعا edema, يعني surrounding edema. Okay, so what do we have here? The first one, the intraventricular one, is the central neurocytoma, and the second one, in general, central neurocytoma and oligodendroglioma have similar histological and imaging appearances. Even histological is different, is the same. Sorry. T2 hyperintense multilocular bubbly content, variable enhancement, calcification. However, the central neurocytoma usually in younger adults, around 20 to 40 years old, they happen. Okay, almost always located in the lateral ventricle. Central, it's same as central, so you should expect it to see it in the central part of the brain. Okay, abutting the septum pellucidum, and acute symptoms may result from ventricular obstruction due to hydrocephalus, acute hydrocephalus. Hemorrhage can occur. Oligodendrogliomas occur in older age group, usually all over 50 years old. Located in the cortex, subcortical white matter, more commonly in the frontal lobes. The growth pattern is indolent and may produce pressure erosion of the calvarium because it's more peripheral than central neurocytoma. Okay? Nice. Good. Central neurocytoma is almost always intraventricular. Oligodendroglioma is very common to be peripheral, cortical, subcortical, and more in the frontal horn. Okay? Never say never. If you say it's impossible, no, it's possible. Okay, maybe 1 in a billion. I don't know. Okay, but common is common. Rare is rare. This is our model. Okay. So, what do you think is going on here? Ring enhancing lesion, target sign, bullseye, also the same appearance. This is the same sign. It's bullseye, concentric target, ring enhancing lesion. Okay, so what's the differential diagnosis here? Wait. Sorry? Okay, exactly as we said, magic Dr. L. Metastasis is one of the possibility. What else? Toxoplasmosis and tuberculoma. Okay. There is ring enhancing with central enhancing. The trick is the central enhancing focus, the central enhancing dot. You know, the bull's eye. Okay. So it's a ring enhancement with a central dot. Can be multiple, can be single. Usually multiple, but if could be. Okay. You can see here the central dot sign. This is the bull's eye, the pupil of the eye. Okay. Again, the differential here is narrower than ring enhancing lesion. Okay. Tuberculoma, toxoplasmosis, and metastasis are the top priorities. Let's talk about the CNS tuberculosis. It occurs usually following hematogenous dissemination from the respiratory or GI. Okay. The superficial infection results in meningitis, cerebritis, whereas the deep infection produces tuberculoma. Where does occur the meningitis? Where more commonly to occur in tuberculoma? Basal system. Okay, and the differential diagnosis will be what? Sarcoidosis is number one. Again, It's a granuloma, non-causating in sarcoidosis, causating in tuberculoma, but whatever. Okay, so the target appearance reflects the central nidus of granulomatous inflammation, which enhance may later calcify. This appearance is not specific and can be seen with other infections, especially fungal, tamifactive demyelination, a disease called BALU, concentric sclerosis. Okay, can give us the same appearance. Partially thrombosed aneurysm and metastasis can give you this appearance. In immunocompromised patient, toxoplasmosis should be considered. Toxoplasmotic brain lesions are usually multifocal with rim enhancement, larger irregular nodules representing combination of inflammation, hemorrhage, and necrosis. In the cortex and deep gray matter, the nodules tend to be eccentrically located, the asymmetric target sign in the periphery, okay? In the deep gray matter, in the central part of the brain, usually the nodule is eccentric, okay? Asymmetric target sign, which is pathologically correspond to necrotizing abscess and penetrating vessels, eccentric, okay? While the deeper parenchymal region may demonstrate more concentric appearance. So the deeper you go, the more central or concentric pattern. And this is specific for toxoplasmosis, correspond pathologically to central hemorrhage. Okay, good. So it's a difficult one, not that easy. Don't think it's very obvious, but anyway, there are some cystic lesions here and here, some faint cysts. If you look like really careful, I don't think that literature will help us here. So this is what's called, I will help you with the sign. This is what's called bunch of grapes or grape-like feature or sign in the Sylvian fissure. Any idea what's the?
This is the first time I see it.
Good. I hope it will be the last. Okay, this is bilateral, exactly. What's called bunch of grapes, grape-like or racemose pattern. It occurs in racemose neurocysticercosis. Okay, there are multiple cluster cystic lesion expanding bilateral Sylvian fissures. We don't see it in our part of the world, the neurocysticercosis. Very, very unlikely, very rare, very uncommon. But as a feature or a sign, you have to keep it in mind. Which is neurocysticercosis caused by what? The Tina solium, the pork tapeworm. Okay. It is the most common parasitic infection of the CNS worldwide and the leading cause of acquired epilepsy. Nice, huh? It likes to be the brain, so preferential deposits in the brain, eyes, and muscle. Location, where in the brain? It includes the subarachnoid, cisternal, parenchymal, intraventricular, and spinal deposition. 5 stages: non-cystic, vesicular, colloidal vesicular, granular nodular, and calcified nodular. Okay, again, non-cystic, vesicular, colloidal vesicular, granular nodular, and calcified nodular. 5 stages. The non-cystic neurocysticercosis, the first stage, is asymptomatic. Okay, no imaging findings. Just don't care about it. We have nothing to add for that. The vesicular neurocysticercosis, there is parenchymal and or subarachnoid cyst with associated scolices. It's called cyst with dot appearance.
Yes.
Cyst with a dot, okay? And little or no edema. The racemose variant, racemose, exactly, maybe mild edema. Wait, don't jump. We're in the stage 1 or 2, okay? Stage by stage, wait, okay? Racemose, it's a Latin for bunch of grapes. Bunch of grapes in Latin is racemose, okay? It is clustered cysts, usually without scolices, just cysts. Typically located where? In the Sylvian fissure, like in this case, basal cisterns. Colloidal vesicular neurocysticercosis is marked by larval disintegration with marked enhancement, edema, and peripheral capsule formation. So when you see edema, when you see enhancement, this indicates the larvae are starting to die. This is a good sign. It's start. It you see enhancement edema. Oh, that's bad. No, it's good. Okay. After that, there will be granular nodular neurocysticercosis characterized by cyst retraction with gliosis. The calcified nodular neurocysticercosis is the non-active stage. Lesion has completely involuted and calcified. Okay, so it starts by nothing, cyst with a dot, some edema, then enhancement and edema and whatever. They start to die and then calcify. Okay, this is the pattern. When you see edema and enhancement and whatever, okay, it starts to die. Not the patient, the cyst. Something that we are all deficient on. What's this? What's the modality? Scoliosis. This is spine and the brain. What's the modality? Nuclear medicine. This is cisternogram using indium 111 DTPA. Intrathecal injection. They injected lumbar puncture and then they follow the radioisotope. Okay, you can see it's ascending up, covering the brain. Okay, what's the sign?
Diagnosis, I think it's CSF.
No, it's not CSF.
Checklist made.
No, it's a very romantic sign. It's a heart sign or a butterfly. I don't know what is the heart. This is the yeah, this is the central part. It should be like the ventricles here are prominent and the CSF flow over the brain, giving it the heart appearance. It is usually seen in normal pressure. This sign seen in normal pressure hydrocephalus or cerebral atrophy. Okay, there is ascent of the tracer from the intrathecal injection site.
This is appearing to head of the anopheles.
Whatever. Okay, intrathecal injection site over the cerebral convexities. This results in the lateral with reflux into the lateral ventricle. Okay,
normally شلون نقدر شلون normal.
that's why I'm telling you we should read the nuclear medicine. Okay, it's a simple sign, very common, and we have nothing what's going on here, and we will see some other things from SPECT and things like that, things that we use in the brain. Anyway, so I will tell you about that. Radionuclear. So no, it's the cerebral, the CSF spaces. We inject the contrast intrathecally. You just see it's a lumbar puncture. You see the CSF flowing wherever. Okay, the radionuclide cisternography uses intrathecal injection of radio-labeled pharmaceutical. Usually it's indium 111 DTPA. Sequential imaging to evaluate the CSF flow. In a normal patient, the tracer ascend in the spinal column to the level of the basal cistern by 1 hour. After 1 hour, you see the basal cistern. Frontal pulse and Sylvian fissure by 2 to 6 hours. Okay? The cerebral convexities by 12 hours and the superior sagittal sinus by 24 hours. So they have to know the timing of the CSF flow. In patients with normal pressure hydrocephalus, there is impaired absorption of the CSF by the arachnoid granulation. This causes early reflux of the tracer into the lateral ventricle. You should not see the lateral ventricle. Okay? Because the lateral ventricle excretes the CSF. The arachnoid granulation absorbs the CSF. When you are injecting the contrast, the radioisotope intrathecally, it should go into the site of absorption, not the site of excretion. It should not go to the lateral ventricle. It should go to the cerebral convexities. When it goes into the lateral ventricle, like here, you can see the heart. Get it? So, butterfly or heart appearance with little flow over the cerebral convexities at 24 to 48 hours. Ventricular reflux and delayed ascent of tracer can be seen in cerebral atrophy, but should not persist by 24 to 48 hours. It's either normal pressure hydrocephalus or cerebral atrophy. You can see it in cerebral atrophy, but not after 24 to 48 hours. Okay? If you see it after 24 to 48 hours, this is normal pressure hydrocephalus. Okay?
Okay.
Good.
Nice.
I think our last sign for this session today. Exactly, this is an easy one. This is a butterfly, or some people call it mirror image. Okay? The differential will be first glioblastoma multiforme, lymphoma, and tumefactive MS. طبعا GBM will be number one always. يعني.
Yes.
Okay? There is a peripheral enhancing bifrontal mass extending through the corpus callosum to both sides, which is the butterfly. However, this butterfly is always a bad news for the patient. It's a bad butterfly, evil butterfly, because usually it involves both cerebral convex hemispheres and the intervening corpus callosum. Keep in mind that the compact structure of the corpus callosum generally serve as a barrier to disease spread because it's so compact bundle of nerve fibers. Okay, so when there is something that involves the corpus callosum, it's aggressive. It must be aggressive to overcome this barrier, like GBM, lymphoma, tumefactive MS. The GBM, which is a high-grade glioma, demonstrate infiltrative margin, shaggy rim enhancement, internal hemorrhage, necrosis. The tumor behavior is aggressive, frequent recurrence after surgery, chemoradiation. CNS lymphoma, the other possible differential diagnosis, generally demonstrates smoother margin, sometimes peripheral notching. Due to the tumor hypercellularity, the lesion will be on CT what? Hyperdense, because it's hypercellular, while on T2 will be iso to low. Okay? The diffusion will be restricted or not?
Restricted.
Exactly, the diffusion will be restricted. Tumor hypovascularity is reflected by what's the enhancement will be?
Homogeneous.
High or low enhancement, the lymphoma?
Rapidly enhancing.
Hypovascular tumor. The hypercellular, hypovascular. So the enhancement will be mild to moderate. Homogeneous, but mild to moderate. Okay? There is marked improvement or complete resolution with what? Steroid. Surprisingly, lymphoma, you just give a steroid and it will be much better. Okay? Tumefactive MS rarely has a butterfly appearance and may demonstrate incomplete leading edge enhancement corresponding to active disease of demyelination. The lesions tend to be disseminated in space and time. This is the diagnostic features of MS, and are variably responsive to steroids. Sometimes it responds, sometimes it's not. Okay, I think we'll stop here and maybe we'll continue, I don't know, let's see, maybe on Thursday or next week. Okay, thank you very much.
Thank you.
Thank you.